Hey everyone, it's Professor Costa. Today we're going to be doing pediatric medication administration, hydration calculations, and dosage calc for special patient populations. Okay, so the pharmacokinetic mnemonic is ADME, which stands for absorption, distribution, metabolism, and elimination. So kids have decreased stomach acid production, and that happens until they're about 1 year old. Just remember, medications are chemicals, and the pH of the environment does affect absorption. They have also slower gastric emptying compared to adults, so it takes a little longer for the chyme to go into the duodenum. And there are medications that are absorbed in the gut and not in the stomach. So all these play a role in how often and how much we administer in terms of pediatric meds. Intestinal flora is, babies are born without intestinal flora, and they become colonized over the first few months with their mom and their siblings' flora. Also remember, kids are more likely to be on antibiotics, and that can also affect the flora. So all of these can impair or impact absorption. Children's skin is thin and porous, so topical medications are more readily absorbed. That also happens with things like lotions, and so just be very mindful you're using children's products when you're dealing with an infant. Distribution, decreased circulation to muscles because they don't have as many muscles as we do. I mean, the size of the muscles. A lot of medications, and this goes for things like chemotherapy for adults, but especially for children. Weights are calculated using body surface area, which takes into consideration their height and weight. Increased percentage of water comprising body weight, so children are more likely to become dehydrated, so be very mindful. Infants have less body fat, so lipophilic drugs are going to be affected within the body. Neonates and infants have less albumin and fewer protein receptor sites. So a lot of medications are bound to plasma proteins. So if you don't have as many proteins, that means there's a lot more free drug floating around. So they may need a lower dose than you would expect by their body weight. Metabolism. So little guys grow fast, so they have an increased metabolism. That may impact the frequency of dosing for things such as morphine. They may burn that off a lot faster. They have immature liver function, so things that are metabolized in the liver, such as acetaminophen, they are at higher risk for developing toxicity. Okay. Elimination and immature kidney function, so they may not clear medications. So again, things like antibiotics, they may have a different dosing than an adult, and also an increased percentage of water. Remember, again, for elimination purposes, a dehydrated child is more likely to become toxic, and they are more prone to dehydration than a grown-up. So, with all that in mind, the mechanisms of action and effect of a drug on the body includes the onset, peak, and duration, and for the effect of a med. The half-life of a med may be different in children than in adults, so never use an adult reference guide. You're always going to use the PD reference guide. Pediatric variables such as organ function, developmental factors, and administration issues affect drug pharmacodynamics. Okay? So how are we going to know if something is a safe dose? So we're going to be determining safe dose ranges. So something called fixed dosing. So dosing applied to homogeneous populations, like an average sized adult. For example, an average sized adult is going to go to the pharmacy and buy Tylenol, and they're going to take the fixed dose for an adult patient. That's not the same for kids, all right? More often than not, you're going to see weight-based dosing for children. So if you go buy Tylenol at CVS, you're going to see it's dosed based on the child's age and weight. Remember, just because someone weighs more doesn't mean that they have an intact, working liver and kidney. So both are considered when we look at a child, right? So the age and the weight. And then some medications, including for adults, things like chemotherapy, are dosed using BSA, or body surface area, and that's dosing based on body height and weight. So weight-based dosing. So if we want to ensure that the ordered drug dose is safe, we would check the drug reference to determine the weight-based recommendation. So we're going to look at a Pedi drug reference. At Hasbro, you have to use their database. And then we're going to calculate. So for someone who weighs, for example, an order for 5 milligrams per kilogram is the recommended safe dose range. We're going to put 5 milligrams over 1 kilogram equals X milligrams over their weight. So let's say, for example, the recommended dose is also 5 milligrams per kilogram, and we have a child that weighs 2 kilograms, then the recommended safe dose for that child is 10 milligrams, right? So we're going to do a little bit more of that. So commonly used conversion factors in this, you must remember, is 1 pound equals 16 ounces, 1 kilogram equals 2.2 pounds, and 1 kilogram equals 1,000 grams. So the rounding rule. We will not round until we're done doing all the math, okay? And then once you round, you're going to convert the weight and round to tenths. So we have someone that weighs 5 pounds 6 ounces, a little guy that weighs 5 pounds 6 ounces. So first we're going to convert the 6 ounces to pounds. It doesn't simply become 5.6. We have to convert that 6 ounces into pounds. So 1 pound over 16 ounces times 6 equals 0.375 pounds. You notice we haven't rounded that, right? So we're going to combine partial pounds to whole pounds. So 5 plus 0.375 pounds equals 5.375 pounds. Still haven't rounded. Now we're going to convert pounds to kilograms. That math hasn't changed. We're same 1 kilogram over 2.2 pounds, and we end up with 2.443 kilograms. Now we're going to round, and we're going to round to tenths. So round 2.443 to 2.4 kilograms. So some medications are done in a single dose. So 1 dose of Tylenol for fever. So we're going to calculate, for this case, a safe single dose of ibuprofen. A child that weighs 33 pounds. Remember, moms are going to be calling into the PD office. They're not going to know their kid's weight in kilograms. They're going to know it in pounds. So the recommended dose of ibuprofen is 10 milligrams per kilogram per dose. So first we're going to convert. Step 1, convert pounds to kilograms, and we end up with 15 kilograms. Then we're going to calculate the safe single dose. 10 milligrams per dose over 1 kilogram equals X milligram per dose over 15. 10 times 15 is 150 milligrams per dose. So that's the safe amount for this child. All right. All right. And then there are medications that are done as a PRN. So, antipyretics and analgesics. So we're going to look at the safe single doses for those. For medications that are done on a schedule, not only do we have to know what the safe single dose is, we need to know what the safe daily dose is so that we don't overwhelm that child's immature organs, okay? And we always want to compare, make sure that they're getting the correct single dose and the correct max, and they're not going over the maximum safe daily dose. So a safe daily dose. So for this medication, the recommended dose is 15 milligrams per kilogram per day divided Q12 hours. So there's a few steps here. First, we're going to convert pounds to kilograms, right? So this child weighs 66 pounds. So doing the quick math, we have 30 kilograms. Now we're going to calculate the safe daily dose. So the daily dose is 15 milligrams per day, right, per kilogram. And we're going to do the math, and we know that the safe daily dose is 450 milligrams per day. All right, so we know that the safe daily dose is 450 milligrams, but that's every 12 hours or 2 doses in 24 hours. So what do? We divide that in half. So 450 milligrams per day divided by 2 doses per day equals 225 milligrams per dose. Now we're going to have a range. Things like antibiotics will often have a minimum and a maximum dose. Why would there be a minimum dose? Well, we want the antibiotic to kill the organism, and if we don't give the person enough medication, then it's not going to do that. Okay, so we would have a minimum and a maximum. So first things first, we have, I put a 185-pound adult because we do this for adults too. So the reference says 15 to 20 milligrams per kilogram per day to be administered in 4 divided doses. So we're going to convert. So we have someone that weighs 84.1 kilograms. So all this means is we have to do the math twice. We're going to do the math for 15 milligrams per kilogram per day, and we're going to do the math for 20 milligrams per kilogram per day. So we're going to have a minimum and a maximum. The minimum is 1,261.5, and the maximum is 1,682. Now we're going to take a look at our order, okay? So the order, and I've messed up the med, so just ignore the name of the medication. We're just looking at the numbers for this. So the order is 250 milligrams, right, of drug X every 6 hours, right? And for our reference, we know the minimum and the maximum. So we're going to figure out how much are they actually getting. So if they're getting 250 milligrams every 6 hours, then times 4 doses in a day, that equals 1,000 milligrams in the day if we gave the medication as ordered. But when we look at the minimum dose, we should be giving a minimum of 1,261 for a person of this weight. Moral of the story is that we should question the order. Now, there may be other mitigating factors. This person may have kidney failure or an impaired liver or something that may impair the elimination of the drug, and therefore we may change, for that particular person, the dosing. But you should question the order. Why are we giving less than the minimum daily dose of this medication? All right. Next up is we have pediatric daily fluid requirement, or DFR. So that's the minimum amount of fluid to maintain normal hydration. It's called maintenance fluids, and it's based on the body weight and using the formula in table 13-1, which you will have for reference on your exam. Here's the table. So for 0 to 10 kilograms, we give them 100 milliliters per kilogram per day. For instance, if we have a 1 kilogram infant, very tiny preemie, their DFR is 100 milliliters because they weigh 1 kilogram. Okay. For a child that's 11 to 20 kilograms, we're going to give them 1,000 for the first 10, and then it's 50 milliliters per kilogram per day. And then over 20 kilograms, they're getting 1,500 for the first 20 kilograms, and then it's 20 milliliters per kilogram per day. So we're going to calculate the DFR, the minimum for normal hydration for a newborn that weighs 3,300 grams. First things first, we're going to convert grams to kilograms. So 3,300 grams becomes 3.3 kilograms. Then we're going to use the formula. So 100 milliliters per kilogram per day times 3.3 kilograms equals 330 milliliters per day. Why do we care about this? Well, we want to make sure that they're not becoming dehydrated. Remember, little people get dehydrated very, very quickly. And we need to consider all sources of intake for the child. This includes IV and PO, or tube feedings. So the DFR must include all sources. We can average out how much they should take in for every feeding. So if we have an infant needing 330 milliliters per day who's only receiving PO, bottle feeds, and they feed every 4 hours, so about 6 feedings per day, we would expect the child to take in approximately 55 milliliters per feeding to meet their DFR. Does that make sense? Okay. So the DFR, again, is a minimum requirement. And we often exceed our minimum requirements. If I feel extra thirsty, I may drink, my extra big gulp. But then we have to evaluate output. So expected output, bare minimum, is 1 to 2 milliliters per kilogram per hour. And in general, output should be approximately 50 to 100% of intake. Okay. Now, why the range? Well, maybe I'm really, really sweaty and I'm losing fluid that way too. So for a newborn weighing 3.3 kilograms, we calculated a DFR of 330 milliliters per day. The expected output, using the formula in red, we would expect them to get 79.2 to 158 milliliters for 24 hours. That's the minimum output. We also want to keep in mind that output should be approximately 50 to 100% of intake. So if they're taking in lots and lots of fluid, then their output should increase, correct? Right? We also don't want their output to way exceed their input. There are some endocrine disorders, for instance, that would cause increased urination, and we need to be just bear in mind that you're eyeballing how much they're taking in and how much they're putting out, and does it make sense?